Thank you very much, Evelyn. There has been some great presentations today, so I'll try to follow in their footsteps. We'll see how it goes. My dear friend Bob, last year, he suffered from severe lower back pain. And he went to see many healthcare professionals, but no one could give him a clear diagnosis and, in turn, an accurate treatment plan. So as the months passed, he grew increasingly frustrated and very nervous about his pain. It wasn't until he saw a physiotherapist who decided to do an ultrasound of the involved tissues that he felt a little bit better. He saw the tissues, and as a result, he could see and understand the problem. And he left the office that day feeling very happy with a good treatment plan. Now, I can imagine how this would comfort a patient. But as a soon-to-be physiotherapist, I can also imagine that having a visual confirmation of your diagnostic choice could offer some reassurance and certainty. This is why I, Megan Kruger, decided to investigate the benefits and the limitations of musculoskeletal ultrasound. And today I want to share with you what I discovered. Now, Bob is one of the many who experience lower back pain. In fact, at this moment, there are approximately 31 million Americans experiencing back pain. Now, that's just in America, so you can imagine the total amount worldwide. This puts a lot of pressure on healthcare providers, especially physiotherapists who have an estimated caseload of 25 to 45%. This disabling condition results in a lower quality of life for the patients and has a global effect on the economy. It is therefore essential that healthcare providers and researchers work together to find the optimal medical care for these patients. Now, it has been shown that there is a connection between lower back pain and the core muscles, which form a stable box around the spinal column. These muscles co-contract to increase the intra-abdominal pressure, and in turn, this decreases the external load on the spinal column tissues by 30 to 50%. Now today, I will be focusing on the front sides of the box, which are your transverse abdominis and your internal oblique. In addition to stability, these muscles aid in the breathing cycle by pushing the diaphragm cranially during forceful exhalation. So breathing could maybe be a useful treatment technique in these patients. Now, apart from the physical examination, this slide shows some of the current techniques used to visualize and observe the functioning of these muscles. So, on the ICF category body structures, we could use imaging modalities, for example, MRIs, but these are very expensive and not very patient-friendly. On the ICF category body functions, electromyography can be used to measure the activity of the muscles. But the transverse abdominis is a deep muscle and would require invasive methods. Other options, such as pressure cuffs or palpation, cannot quantify the activity of the muscles. In fact, several domains of the ICF cannot be measured to the fullest extent. So this brings us to musculoskeletal ultrasound, which is an increasingly popular imaging tool used by many healthcare professionals. This tool is beneficial for several reasons, as you can see on the slide. In fact, one researcher was so bold to say that the MSU transducer is synonymous for a physician's stethoscope. But the device is user-dependent and has a long learning curve. So it could be that perhaps some healthcare professionals are not as good at scanning than others. In fact, only one study has investigated the interprofessional reliability, and they found that the agreement between the two professions was only moderate. So this brought me to my two research questions, which you guys can now read on the slide. So basically, to summarize, my two main goals were to investigate the interprofessional reliability and the best clinical protocol. Now, Evelyn already told us a little bit about how we went about doing our experimental study, but just to give you guys a quick summary again, this is the device that we used. It's an SAO device, and it is commonly used in physiotherapy. And we decided to use a linear transducer to visualize the soft tissues on the screen. Now, if you imagine that this is the stomach, the transducer had to be placed gently against the skin and perpendicular to the tissues, so at a 90-degree angle. And the location was as seen on the image. Three pictures were captured at each breathing moment, and the picture on the right illustrates what we saw. The thickness measurements were done using a standardized protocol. The light blue line indicates the thickness of the transverse abdominis, and the dark blue line, the thickness of the internal oblique. Now, the reliability was calculated using two statistical tests, but I'll keep it simple. The ICC looks at the reliability, and the closer to 1, so the results, the closer to 1, the better it is. The standard error of measurement looks a little bit more at the accuracy and the precision, and here you want the value to be as low as possible. Now, in total, I had 67 participants between the ages of 18 and 28 who participated in my study. When we look at all 4 assessors together, which are 2 speech therapist students and 2 physiotherapy students, we see that the reliability is excellent. So it could be suggested that MSU can be used to measure the 2 muscles at the 3 breathing moments. But as you can see, the reliability is lowest at exhalation. This is possibly due to biomechanical reasons. As the muscles contract, they compress the content in the abdomen, which changes the architectural shape of the muscles. Now, as I mentioned, my biggest purpose of this study was to investigate the interprofessional reliability. But my statistical results showed me that there is no clear pattern, as neither the physiotherapy pair nor the speech therapy pair scored consistently higher. So I can therefore not conclude if one profession is better at MSU than the other. This is most likely due to the fact that in my study, all 4 assessors received identical training. My secondary purpose was to see if single thickness values are sufficient or if clinicians require average measurements. Now, when I used mean values, the reliability and the accuracy for both muscles increased considerably. Researchers found that there is a reliability threshold of 2 measurements when you measure at rest and voluntary contraction. But I recommend to use an average of 3 measurements during the breathing cycle because the muscles are slightly more difficult to visualize. Now, apart from using average measurements, there are several factors which could influence the diagnostic accuracy of MSU. Now, as we cannot choose our patients in practice, and often we do not have a choice on the equipment, I'll be focusing on the task and the operator. Stance and respiration were both innovative and functional for our experiment, but the reliability can be lower in stance because the transducer is more prone to slipping downwards due to gravity. I suggest using the ulnar aspect of the hand as an anchor against the patient's skin to prevent the transducer from sliding away. Standardizing the breathing was also a really big challenge. Okay, to wake you all up right now, I want all of you to breathe in as far as you can. Go, 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 come on, come on, come on. And relax. Who of you noticed that with some verbal motivation, you could go slightly further? Who of you used your chest to breathe, and who of you used your stomach? These are all aspects that are extremely difficult to control during the experiment because breathing is effort dependent. My main recommendation is to scroll through the last recorded MSU images to select the image that shows the maximum moment. It is most likely that the biggest limitation to diagnostic accuracy, in MSU diagnostic accuracy, is operator inexperience. But the big question is whether the problem lies with capturing the image or the measurements themselves. So researchers asked assessors to measure the exact same image, and they found excellent reliability. So it can therefore be assumed that the biggest problem that operators make is with image acquisition. Now, one big problem is the location of the transducer. Researchers have shown that the morphology of the transverse abdominis and the internal oblique, so for example, the thickness of the muscle or the fascicle orientation, has regional differences. So you can have different reliability or different thickness measurements depending on where you scan. Other flaws include the angulation of the transducer and the amount of pressure that you use. Operators must take into consideration the inward and the outward pressure generated by the abdominal wall during breathing. Now, to provide a good treatment plan for our dear friend Bob here, I suggest to do further research to investigate the respiratory function of the abdominal muscles in lower back pain patients, because I believe that this could be a valuable treatment exercise for this patient population. I also suggest to conduct further research to investigate if any professional discrepancies exist in professionals who currently use MSU in daily practice. To conclude, my results have shown that the device itself is a promising addition to clinical practice, and that the main problem lies with the operator's experience. The responsibility is therefore on the healthcare provider, regardless of their professional background. With proper MSU training and knowledge in anatomy, I believe that all healthcare professionals could use MSU device in clinical practice. Thank you very much. Any questions?
So would you recommend the MSU to medical caregivers? So would you say that it's worth their time and money to learn how to use it?
The device itself is, well, it's one of the cheaper devices that is on the market. It's about 20,000 euros. But like I said, there are many benefits of this device. For example, how portable it is. So it can even be used, for example, on the sport field as a screening tool. And I really believe that it is a valuable device because it can be used on nearly all steps of the clinical process. And as long as healthcare professionals keep in mind what it exactly measures, there shouldn't be a problem. Because it has been shown that the activity, if you use EMG, electromyography measurements, and the change in thickness of the muscles, have a linear relationship till about 30% of maximum voluntary contraction. So as long as you have, as long as you remain critical, like we're taught in university, I believe that it is a valuable tool to use.
Okay, thank you.
Okay, my question is, do you think is ultrasound a good diagnostic tool for low back pain? Because we know at least in school, they taught us that there is a little correlation between diagnostic imaging, so MRI, ultrasound, and actually the real cause of low back pain. So, for example, a patient, you see the multifidus is in atrophy, but is it really good for a patient to see it?
For a patient to see it
exactly.
themselves? Well, I think that, for example, lower back pain has, if you read, for example, the KNGF guideline, they're grouped into different subgroups, and it is very common for patients with low back pains to develop kinesiophobia because they're scared, they do not understand the pain, they don't know where it's coming from. So I believe that if they can actually see the problem and know what it is that is causing this pain, it might offer them some comfort. Yeah?
I just wanted to ask why you think that, why breathing is so important for the treatment of lower back pain.
Well, the lateral abdominal muscles, they have two main functions. So the one is the anticipatory postural adjustment, so, to contract the muscles before any limb movements. And the other one is in the breathing cycle. And at the moment, one of the main exercises for the lateral abdominal muscles is the ADIM, the abdominal drawing in maneuver, which requires that the patient actively and voluntarily and consciously activate these muscles, which is an extremely difficult concept for many people to grasp and might be a difficult treatment exercise. And they've actually shown in the research that when you compare the maximum voluntary contraction to maximum exhalation, the muscles are significantly thicker at maximum exhalation. So the problem is that it is for a different function. It's not the anticipatory postural adjustment, but it is still a way to contract these muscles. And perhaps in patients with kinesiophobia, it could be a valuable starting point for treatment.
Thank you.
Hi, Megan.
Hi, Nico. How are you?
So, my question is, if I don't remember wrong, is about low back pain is 90 or 95% of the time is aspecific, right? So we don't know the cause, and that's very frustrating, right, for us. Do you think by using MSU in clinics, in most of the clinics, or by using it in statistics, we could decrease these numbers, or we would work with it still in that little percent that is known why the cause, let's say?
Well, there's still a lot of research lacking. So, for example, some articles that I read said that there is atrophy in lower back pain patients of these muscles, and other articles said that there's no resting atrophy, because a lot of the standard reference values for different age groups, different sex, different length, height, all those things are still missing. So that is why research that Evelyn conducted is also so important. So that is a sort of a way around your question. But basically, it's not entirely sure how much you can actually really see to see if you can diagnose them of having a problem with their lateral abdominal muscles in lower back pain. A lot of research still needs to be conducted with that. But I think that it's still valuable in the sense that when you then start doing your treatment, you can compare the muscles beforehand to as the treatment progresses. So I still think it is a valuable tool.
That's good.
Yeah?
Yeah, thank you.
No problem.
We're just gonna keep shooting questions, of course.
No
So
problem.
we noticed the integrated reliability on the exhale was least reliable, and you said, no, it doesn't matter what you said. My question is, what is the exact moment you took the image when your subjects exhaled?
Yeah, that's what I was saying. It's difficult to standardize because we wanted the maximum moments. And now research, because we sort of looked at the research for spirometers, and they said that within the first 5 to 6 seconds, you should reach your maximum moment. But as you maybe also experienced when I told you to breathe, you can see that there isn't a certain cut point where you say, okay, this is your maximum. And that's why I think when you scroll through the images, because it's possible to, if you record an image, you can scroll through the last, I don't know how many seconds, but a lot of images. So our standardized protocol was sort of to select the muscle that was either the thinnest or the thickest, the picture that had the thinnest or the thickest. But this is something that is really, really difficult to standardize.
But you standardize it even though.
We tried.
Super. Excellent defense.
Thank you.
Hi. I just wanted to know why the angulation of the transducer is so important.
Well, basically what happens is that there are crystals in the transducer. And what it does is that it sends the sound waves through the tissues, to subcutaneous tissues, your muscles, etc. until it reaches the bone, and then it reflects it back to the transducer all the way through this cable to the MSU screen. And if you change the angulation, then it doesn't reflect the same way back to the MSU screen. And researchers actually started to investigate what amount of degree you could use to not change the image. And they were very, very happy with the results, which I find a little strange. But up until 5 degrees of tilting would not change your image. Only 5 degrees. So it is really, really important that you try and keep it as perpendicular as possible. Thank you. Yeah, okay. Thank you.